Welcome everybody to this session on SUDEP, or sudden unexpected death in epilepsy. SUDEP is increasingly being acknowledged as a major form of death related to epilepsy. We're still struggling with the whys, hows and what to do in terms of preventing it. This session has three speakers who are going to present work looking at mechanisms of SUDEP, and we're also very honoured to have our plenary lecturer here for Melbourne Epilepsy. He's just arrived and is a bit sleep deprived, but he will be able to give us an overview of SUDEP. I'm going to present Vanessa Sanger, who's from the Technical University of Dresden, who's going to introduce us to our plenary speaker.
Thank you. It's my pleasure to introduce the first speaker, Philippe Ryvlin. As you can see there, he is with the Department of Clinical Neurosciences in Lausanne, of which he is a professor of neurology and the head. And he's the director of the Epilepsy Institute in Lyon, in France. And amongst other positions, he's also the chair and he coordinates the European Network of Cooperation in Epilepsy Surgery, funded by the European Commission. And he has many research interests, and his main interests at the moment are SUDEP and epilepsy surgery. And yeah, this is a special pleasure to welcome with you, Philippe, to the board.
Well, thank you very much, Vanessa, for this kind introduction. Thank you, Anna, also. And I would like to thank Levin Coleman, who managed so perfectly everything for my presence to this conference. And I'm sorry that I stressed him those last hours because I had some problem due to my visa in Dubai. But finally, I make it. I'm very happy to be here once again. I know Melbourne has been rated #1 city in the world for many years. I don't know if it's still the case. Nevertheless, for me, it's the #1 epilepsy city without any doubt. And you have the richest component of researcher in the field, both basic and clinical, and everything that come out from the city now is so amazing. It's an honor for me to be here. So I'm not sure I need the microphone. The last speaker did a very good job without the microphone, and I had a loud voice, so let me try to shift to my computer, and if you don't hear me well, just tell me, I'll come back. So is it okay? So I was asked to discuss SUDEP in general as an introduction to that session. And as you'll see, I will discuss first some epidemiological aspect, then spend some time on the mechanism and pathophysiology of SUDEP as we understand it. It has progressed over the last decade quite dramatically to the point that in the past we used to say sudden, unexplained and unexpected deaths, and now it's clearly unexpected, but no more unexplained for the most part. And we'll conclude by discussing what could be the way to prevention for this most dramatic outcome in epilepsy. So SUDEP is one of several reasons for premature deaths in epilepsy. And premature mortality in epilepsy is really an issue. This is one of the latest and best designed study performed in Sweden, nationwide, completely population-based, looking at mortality in patients until 55 who had a recorded epilepsy in the country. And to make a long story short, the odds ratio for the risk of dying when you have an epilepsy before the age of 55 is tenfold higher than that of the general population. Unfortunately, in this very nice study, you have no clue about SUDEP because, as we'll discuss later on, it's quite difficult to have this information from any kind of national database on the living status and the mortality of people. But definitely, when we discuss premature mortality, SUDEP play an important role in epilepsy because of its age distribution, which is now well known and well reproduced among all the work that has been done. It picked up around 35 years old. It started primarily in adolescents, even though there are a few cases of SUDEP in children, fortunately not too many, but it peaked in the fourth decade. Even though it's not that frequent overall, and we might discuss this again, it appears to largely contribute to what is called the number of years of potential life lost when discussing the neurological cause of potential years of life lost. And it comes just second after stroke, which is quite dramatic. Now, this, in fact, represents a very heterogeneous situation because the risk of SUDEP is extremely diverse depending on which type of epilepsy population you look at. And in fact, between the lowest and the highest figure, you have a 100-fold difference. So the figure in epilepsy in children in general, or newly diagnosed epilepsy, can be as low as 0.1 per 1,000 per year. And in patients with very refractory epilepsy that has been selected for pre-surgical evaluation or operated and not cured by surgery, it can raise up to 1%. So it's really a huge range of risk. Part of the problem in the different figures that might have been published in the field is also the definition. And the definition has been slightly changing, but I need to make it clear for every one of you and those who are not specialized in SUDEP. So it's exactly what SUDEP means. It needs to be a sudden death, unexpected, that if the patient is not, of course, having an accident, suicide, committing suicide, or having some kind of terminally ill disease. And one element is it's supposed not to be in relation to status epilepticus. So most of the time we don't know because it occurs at night and the patient might well have several seizures in a row and nobody will know. Beside this, even though I agree with this definition for some practical reason, in many cases the mechanism that can lead to death from status epilepticus and SUDEP in general might well be the same. This can be debated. But anyway, for the moment, for the present time, status epilepticus is excluded from the diagnostic of SUDEP. And then you're supposed to find no specific cause. At pathology, if you have pathology, and then it's a definite SUDEP. And if you don't have pathology, it becomes a probable SUDEP. We'll discuss what can be the situation if the patient has some kind of cardiac arrhythmia or genetic mutation that can promote such arrhythmia, let's say long QT syndrome. Well, currently, according to the definition, this will be a definite SUDEP, or probable SUDEP, depending on whether pathology will be available or not. That could be considered plus or not, depending on the way you want to interpret this definition. But overall, the patient will have a sudden cardiac death because of a long QT syndrome, and who otherwise have epilepsy, fulfill the definition of a sudden unexplained death in a patient with epilepsy. Now, the real issue, beside the number I showed you, at the individual level, is the cumulative risk of SUDEP. And that's where the figure becomes really impressive. And that's where we face a major burden for each of our patients who are suffering from refractory seizure. This comes from this very nice work done in Finland, where the patients were selected in a non-biased epilepsy, children epilepsy population. They were selected at the time of epilepsy diagnosis, all type of childhood epilepsy considered, and they were then followed 40 years by the same physician. And that has allowed to have a very precise figure on the risk of death, especially for those patients who had a childhood onset epilepsy who was never fully controlled, or at least not fully controlled during the last 5 years of follow-up. And look at the figures. Among the 245 children, half of them were not controlled during the last 5 years. And among those 107 patients who were not fully controlled, half of them have died before the age of 45, half of them. And among the cause of death, SUDEP represented a very significant proportion. So that means that for a patient who starts epilepsy in childhood and will not be fully controlled by the age of 45, he will have had 1 chance out of 5 to have died of a SUDEP. And that's the individual cumulative risk for such a patient, and that's a huge figure. Now, often when we discuss with neurologists of our perception of the risk of SUDEP, especially general neurologists, we kind of disagree because most of the general neurologists do not have that perception that SUDEP will be that frequent. And they will say, well, I never encountered one, or maybe one. But it's just a question of perspective. Using the same number, you can have indeed very different perspective. I just mentioned the individual perspective of a patient who will suffer uncontrolled seizure for 40 years. Now let's see the general neurologist. He's working for 20 years. He's seeing on average, is following on average 100 patients with epilepsy. And because it's not a specialized center, let's assume only 1/4 of them, rather than 1/3, are not fully controlled. And in that population, the average risk is about 4 per 1,000 patient year. Also, we have to consider that a doctor and a neurologist is not necessarily aware that his patient will die for some reason. And we investigate this issue in France, and we found that on average, doctors and neurologists, including those who have performed pre-surgical evaluation, have followed a patient for years and years, will be aware that the patient has died in only half of the case. So in that typical situation, how many SUDEP will this neurologist be aware of? If you have a very performant brain, you should have already the number. Typically, this patient, this doctor should have had in his patient population 2 SUDEP over 20 years, and he should have been notified of only 1. So that's the opposite perspective, but with the exact same number than from the Silampa paper. It's the same number. Now, in terms of risk factor, because we have this diversity of risk of SUDEP, we would like to identify as precisely as possible who are the patients with the greatest risk and who are the patients with very low risk. This is a list that came out from this pooled analysis of the base prospective case control studies. And as you see, there's one very clear dominant risk factors, which is the presence and the frequency of so-called generalized tonic-clonic seizure. I'm saying so-called because we have to discuss that in a few minutes in a little bit more detail. The frequency is important. We'll discuss genetic of SUDEP today, and there has been paper looking at important issues, taking into account the presence or absence of a convulsive seizure, but if they don't take into account the specific frequency of those type of seizure, they lose most of the information. The odd ratio is huge if you have more than 3 such seizures a year, but if you have only 1, it becomes significantly less. There were other risk factors, all of them associated with odd ratio or relative risk below 2, so with much less impact. And in that first crude analysis, it was only univariate findings with potential confounders. So this was reanalyzed again, and through these re-analysis, it was specifically looked at whether polytherapy, which is a factor on which we can act as doctors, was really a risk factor, an independent risk factor for SUDEP. And integrating the number of generalized tonic-clonic seizure and the number of anti-epileptic drugs eventually showed that the number of anti-epileptic drugs had no independent impact. It just reflects the severity of the epilepsy and the frequency of generalized tonic-clonic seizure. So overall, to conclude on this first epidemiological part, SUDEP is unfortunately relatively frequent, especially if you consider the cumulative risk for an individual with uncontrolled epilepsy starting in childhood. And it has one major risk factor, which is the frequency of generalized tonic-clonic seizure. So this is now a nice scheme that has been developed by Orrin Devinsky in his excellent review on SUDEP in 2011 that show how multifactorial this problem can be. It's, of course, a theoretical framework. Very few of all the arrows presented here has been clearly demonstrated to be at stake. But let's say that most of it makes sense. And I'll discuss very briefly genetic because most of the talk after me will go into that detail with people who have much more expertise than myself in the field. Note that, of course, seizure might play a role, but not necessarily, and that epilepsy and the condition underlying epilepsy could well be the cause of SUDEP in some patient, and that it does not have to necessarily be triggered by a seizure. Now, a few words about genetic. Clearly, there are some patients with gene mutation, typically in gene coding for ion channel, that are both expressed in the heart and in the brain, including some that are clearly associated with cardiac disorder and sudden cardiac death through long QT syndrome and Brugada syndrome. You got a list of the main one here. And we know now that some of those patients, a significant proportion of those patients with this mutation also can suffer epilepsy. We have to sort out these who will have convulsive syncope due to this cardiac problem and will not really suffer from epileptic seizure, from the true epileptic seizure case, but definitely there are patients with clear-cut EEG abnormality and clear-cut epileptic seizure on top of their long QT syndrome or Brugada syndrome. So here, indeed, it is understandable that this patient might well have SUDEP in relation to a genetic disorder, possibly through the same mechanism than the sudden cardiac deaths that are observed in patients with long QT syndrome alone. And conversely, there are some genes that are clearly responsible for well-known epileptic disorder, like the Dravet syndrome and the SCN1A mutation, in whom we know that this mutation is associated with some cardiac abnormality. And that has been demonstrated in Dravet syndrome. So here again, it makes sense to hypothesize that this patient will, on the one hand, suffer from epilepsy, and on the other hand, from a cardiac condition that could be responsible for the sudden cardiac death. Now, there are more recent data looking into this issue in a more complex way, and this has been very recently published using genome-wide analysis of all the exome, and showing in that case, in a case-control study, that patient with SUDEP, in that study it was 18 patients altogether, so it's a small sample, had increased so-called genome-wide polygenic burden of deleterious genetic variants than both leading epilepsy control and disease control. And there were also a difference in the number of variants. So the distinction between the burden and the number of variants is that when you calculate the burden, not only you take into account the number of variants, but their potential for being deleterious variants, depending on what kind of gene is affected, what has been the pathology already associated to that gene. Personally, I still have some problem trying to understand how, or trying to interpret this kind of findings. And the difference of having a burden of 280 in disease control and 320 in patient who had a SUDEP. So this difference between these two numbers, how will that really reflect in terms of promoting the risk of SUDEP? And the conclusion of that important paper doesn't make this interpretation more easy, because overall, their own interpretation is that there might be up to 1,000 genes involved in that increased burden that could be associated to SUDEP, 1,000 genes, or at least 373 that were found exclusively in the SUDEP population. Understanding how that can result in something that looks relatively homogeneous in terms of the mechanism I will describe thereafter, it is not trivial to me at the moment. To conclude on the genetic aspect, and again it will be presented to you in more details immediately after my talk, let's keep in mind that there might be different possibilities for a genetic mutation to translate into a SUDEP. What I mentioned already, a sudden cardiac death through a long QT syndrome, a Brugada syndrome. This is something that is well known, and is including in terms of molecular and cellular mechanism by cardiologists who's been working on this for many, many years. We can also think that in patients with this kind of mutation, it might need a seizure most of the time to trigger the SUDEP. That is, they will have a specific sensitivity in their cardiac activity, but it will be revealed only during the seizure. There might be also the possibility that in those patients, the gene defect will be responsible for the heart to suffer a more chronic disorder following recurrent seizure. And we know that there are some subtle abnormality in a number of patients with SUDEP at autopsy. Recently, there were more emphasis on the possibility that gene mutation could have an impact on how the brainstem responds to a seizure. And as you will hear in a minute, we believe that in the majority of cases of SUDEP, the problem lies in how indeed the brainstem will manage what will happen on the seizure will propagate to its different nuclei. And there might be there different issues that we'll discuss a little bit in more detail. Now, going to a more simple aspect of pathophysiology. The MORTEMUS study basically just wanted to do something very trivial, try to see what happened during a SUDEP in a patient who is recorded for other purpose. And the best information we can have is from epilepsy monitoring unit when patients are there for recording their seizure. And unfortunately, from time to time, a patient will die in hospital in those circumstances. So, because it's extremely rare, the only way to have a significant amount of data was to collect them worldwide, and that's what we did a few years ago. And as you see, eventually we came out with 10 cases that were really informative. You need to understand that they are not representing the entire population of epilepsy. And for instance, patients with idiopathic generalized epilepsy are very unlikely to be found in that series because they do not undergo pre-surgical investigation, and so they are much less frequently recorded in epilepsy monitoring unit. So there is kind of a bias here in the population that is recruited. And this is to keep in mind when you will see the relatively homogeneous mechanism that lead to SUDEP. We might have exclude other mechanisms simply because it do not happen in the population that goes to EMU. So all the cases we encountered died in a patient who had generalized tonic-clonic seizure. We already knew that that was a main aspect of SUDEP and a main trigger, but not to the point that it will be always the case, at least in that specific situation in EMU. The patient I'm showing you did not die, but the seizure he suffered is extremely comparable to the one I observed in all the other cases. So typically generalized tonic-clonic seizure, secondary generalization, occurring at night in a patient who is by himself, no nurse, no doctor being there to watch on him, and turning prone during the seizure. with the head in the pillow and having a true secondary generalized tonic-clonic seizure. That is, it happened a little bit, a few seconds before. Had first his focal discharge, and then you saw at one time he had this typical movement, bilateral, symmetrical, tonic extension, and then the bilateral and symmetrical clonic movement. There's a lot of patients who are believed to suffer from secondary generalization who do not have this pattern. They simply have asymmetric posturing due to the involvement of the SMA or other region, and then they will have clonic movement on one side, then on the other side. They can even keep conscious during bilateral clonic movement if it just involves both central region. And those are really very different type of convulsive seizure. Soon there will be a paper that we perform with my colleague Sylvain Haas, published in Neurology, where we look at this issue in detail. And for instance, if you look at the postictal EEG suppression, that I will discuss in a minute, it almost exclusively happened when the patient had this bilateral tonic extension, reproducing the, let's say, the true generalized tonic-clonic seizure and involving probably the brainstem network. So that was the case in that patient. Fortunately, he survived. That's one of the questions, why some patient will survive. Most of the patient will survive after this type of event, all alone at night, secondary generalized tonic-clonic seizure, head in pillow, still. And why other will die after having suffered many such seizures in the past, that's part of what we would need to understand. Anyway, moving a little bit forward regarding this mechanism, what was really interesting was to see first that the cardiorespiratory arrest never occurred during the seizure or immediately at the end of the seizure. It happened postictally in all cases. And there were basically two possibilities. Either a major cardiorespiratory dysfunction occurring within the next 3 minutes, and that will lead to the terminal cardiorespiratory arrest. And this is what you see here. So you have, for an individual patient, his heart rate, his respiratory rate, the seizure stop here. 0 is the beginning of the postictal phase, and you see that he's breathing more rapidly than normal. He's tachycardic, and then suddenly both respiration and cardiac activity collapse, if you wish. Then it's the terminal cardiorespiratory arrest. In other, we will have the same pattern during the first 3 minutes, but after some 20, 30 seconds, cardiac and respiratory activity will resume. Usually they will be abnormal, and especially respiration will look and sound very ineffective. But still, it will resume, it will continue for some minutes, and degrading again progressively and stopping after 5, 6, 7, 8 minutes. So here, interestingly, you see the respiratory pattern in all the 10 patients for whom we had that information. So again, sorry, each line is a patient, and the postictal phase is the 0. And so you can see that in all the patients, within the 3 first minutes, there will be a respiratory arrest, either transient or terminal. And in most of the cases, it's relatively brutal. And in most of the cases, there is rather polypnea at the end of the seizure. So obviously, this indicates that something is happening postictal, immediately postictal, very rapidly. And this is where we can speculate, and we can only speculate at the moment that some specific mechanisms are at stake in a patient that probably is already in a severe hypoxia. That's what we believe. Hypoxia that can be promoted by a number of factors, including the prone position and the fact that during the true tonic phase of the generalized tonic-clonic seizure, doesn't breathe anyway. And we know that for centuries. Possibilities of a release of adenosine or excessive release of adenosine, maybe endogenous opiate, and more recently, the notion of spreading depression has been also put forward. This is a new scheme that tried to detail what could be the role of the upper brainstem dysfunction in compromising arousal, primarily, and spread to the lower brainstem that control the cardiorespiratory center, and how both dysfunction could be synergistic to result into final cardiorespiratory rest. Postictal EG suppression, just a few words to tell you that this has been observed in all the cases we recorded. This has been reported in other cases before. This is supposed to be a risk factor for SUDEP when it is observed and when it is of long duration, so it has been a controversial issue. But I think for most investigators now, it looked like a surrogate marker of a brainstem dysfunction rather than the cause of anything. I wanted to allude briefly to this very recent work from the group of Jeff Nobles because it's quite elegant, and it let us come again to genetic. Basically, the hypothesis they had is that some mutation might promote abnormal spreading depression in the brainstem following a seizure, and that spreading depression could lead to the cardiorespiratory collapse and terminal arrest. So they look at two mice models, for which they have the knowledge first that they are suffering from seizure. Secondly, that they die young. Many animals will suffer sudden deaths, and that they might well have a decreased threshold for spreading depression. And basically, what they did was first to investigate that spreading depression with different techniques, including injecting potassium, reducing oxygen, and demonstrating that indeed in these two models in the brainstem, there was a lower threshold to get to a spreading depression. And secondly, they developed or triggered seizure by injecting on the cortex 4-aminopyridine and demonstrate that the mutant mice will die in a very high proportion of cases, not the wild type. And when looking at what was happening in the brainstem, there was a clear time correlation between this spreading depression that will occur acutely in the postictal phase, not during the seizure, sorry. The seizure is here, so in the postictal phase, and the cardiac and respiratory dysfunction. So when you look at the figure, it is not clear what is the first element, and it seemed to vary from one seizure to another. So that's where we are in terms of understanding of the pathophysiology of SUDEP. To go very rapidly now in terms of prevention, let's be clear, there is no treatment to prevent SUDEP that has been demonstrated as effective. There is this meta-analysis we performed some years ago that just compared the rate of SUDEP in patients with refractory epilepsy receiving a new anti-epileptic drug versus those receiving placebo. So it's a controlled, randomized situation. And pulling together all those studies, it was found that patients receiving placebo have 7-fold higher risk of SUDEP than those receiving a new drug. Those studies are short-lasting, so what we observe is for 3 months duration. It might not be meaningful for a patient with chronic epilepsy. And for me, the main message here is that it indicates that maybe optimizing treatment, that's how you can interpret the fact of adding another drug in a patient who is refractory. Optimizing treatment might bring some benefit, at least short-term benefit. Epilepsy surgery, it's progressing in different ways, but whether it does really protect from seizure, we still don't know. There are no good study that has been able to really demonstrate this with high-quality evidence. Vagus nerve stimulation, there's this seminal paper from Anigers, who was quite active in the field of SUDEP, including for its definition, and that look at the impact of vagus nerve stimulation in a relatively large number of patients at that time, and tend to suggest that after a number of years of vagus nerve stimulation, the rate of SUDEP will decrease. For some reason in that paper, there was no statistic, there were no confidence interval regarding the rate of SUDEP, so we cannot conclude whether the difference they observed was significant. Much more recently in UK, a similar study was performed on a smaller number of patients, but was almost equivalent patient years of follow-up, and it concluded that there were no significant difference between 2 years, the first 2 years of treatment and thereafter. So we now reinvestigated this issue with Cyberonics and a number of investigators, but taking advantage of much larger population, since we're looking at all the patients that has been registered in the US. We're not talking not of 400, but 40,000. And this translates in many deaths that makes the problem of SUDEP adjudication quite complicated. And what I'm showing you, the preliminary result we will present in Istanbul, and basically they seem to demonstrate that there is a trend for a reduction of SUDEP rate over years, even though there is this surprising increase at 10 years, for which we have no clear explanation, except that some patients after 6-7 years start having the battery which is low, and some of them will not replace it timely. And that might result in a rebound effect, but that's purely speculative at this time. And clearly, even with including this 10 years rebound, there is a statistically significant effect at the level of this huge population. There are still some problems that need to be tackled, and especially the fact that in the same population, we have two factors combined. One is aging, because we follow them longitudinally, and the other is duration of treatment. And aging can have an impact on the risk of SUDEP. In this population, because the median age is about 35 years old, supposedly the SUDEP rate will decrease in those older as a function of aging, but it will increase in those that will be younger than 35. And overall, we believe that should not impact the result I'm showing you, but it still needs to be demonstrated and properly analyzed. I'm almost over, so I will go very rapidly regarding the other potential treatment, because they are clearly also very speculative. Serotonin, there's a lot of argument to believe that it could have an impact. It definitely regulates the lower brainstem center and the cardiorespiratory function centrally. If you look at all the evidence accumulated for the sudden infant death syndrome, which has some reminiscent aspect of SUDEP, it definitely can play a role. But for the moment, there's no study going on. There has been 2 studies looking at an ancillary marker, post-ictal hypoxemia, one in the US that could not recruit more than 3 patients and that has stopped. Another that we've been leading in France, we also had some problem recruiting patients, but we'll soon reach the 80 patients that was our objective. And we'll see whether at least it has an impact on post-ictal hypoxemia. Regarding adenosine, as I mentioned, it's an interesting possibility to see whether or not this could be a way to prevent SUDEP. And that lead us to discuss caffeine. And for some reason, caffeine, which we know can have an impact on the adenosine receptor, has been very ill studied in epilepsy. That's something certainly we should look at more in detail in the future, because there is a potential for caffeine, low-dose caffeine in the evening, to be protective. Opiate. There is one study that we have just started looking again at an ancillary marker, post-ictal hypoxemia, by simply injecting naloxone in those patients having a generalized tonic-clonic seizure and developing postictal hypoxemia. And if that proves successful, then there could be a rationale to try chronic treatment with naltrexone, which is an inhibitor that has been largely disseminated and used in patients with chronic alcoholism, and for which we have a lot of safety issue that it's not pro-epileptic, and that might indeed have an impact on SUDEP. The main problem for doing prospective trial, randomized trial of preventive intervention for SUDEP is that if you just recruit patients with refractory epilepsy, you face a problem of sample size. If you look at an intervention that will reduce by 50% the risk of SUDEP, with the current risk of SUDEP in refractory population, you will need to randomize 6,500 patients and follow them 1 year. It's simply not feasible. That's why the next step to go to SUDEP prevention, beside progressing in understanding and mechanism, is to find new biomarker. New biomarker above generalized tonic-clonic seizure that will help us selecting a population which will be rather between 2 and 5% risk of SUDEP at a specific stage of their disease. That will be the only way. How we will do that? Maybe genetic will help, I hope so. Definitely, I think it should come, and that's very relieving from this conference, through all the seizure detection system, either implanted or non-implanted, that are being developed very actively at the moment. And maybe even the systems will be able to carry with themselves the possibility of an intervention like the classic cardiac defibrillator for patients at risk of sudden cardiac death. But this is still to be performed, and it's not going to be an easy way. To conclude, I'd like to remind you the importance of this problem and the frequency, and especially the cumulative risk for patients with childhood epilepsy and uncontrolled seizure. Remind you the main risk factor, we discussed it several times, frequency of generalized tonic-clonic seizure, but if you want to study this appropriately, you need to find a way to distinguish a true generalization from the others, convulsive type of seizure. Mechanism of SUDEP, as we understand them, seems to primarily be related to a generalized tonic-clonic seizure, which will end by a neurovegetative collapse, cardiorespiratory collapse in the aftermath of the seizure. Many potential interventions. That's why I think the field is very exciting. I think within the next 5-10 years, we should really be able to progress in the same way there has been major progress, like in the field of sudden cardiac death and sudden infant death syndrome. But the most urgent need, as I mentioned previously, is to develop new biomarkers. And again, I think what you're discussing here at this conference for other purposes, especially as a seizure detection system, is extremely relevant to that objective. Thank you very much for your attention.
Thank you very much for a really excellent overview of SUDEP. Now we can squeeze in some questions, and I request to counter the Australian accent. Can people please speak clearly?
Clinically, we certainly see patients who develop seizure-related bradycardia and even sinus problems when we're monitoring these patients. I found when I sent these patients to cardiologists, they're very reluctant to place pacemakers in them, but I just wonder if these people aren't at greater risk. And I'd also just like to ask, for people who are at high risk, there's the possibility of placing a cardiac device, but there are also diaphragm pacemakers now that would be another option. So could you comment on that?
Yeah, that's two very important questions. So regarding the first one, I think we do have to distinguish the ictal systole that we see on a regular basis. And if you remember the John Bentham study some years ago published in the Lancet, putting breathing system in 20 patients with uncontrolled epilepsy, eventually 4 said, it was quite an important figure, had an ictal systole at some point, or a severe bradycardia. We don't have the answer whether this patient should be paced, But for the moment, what we can say is that, to my knowledge, there has been only one case, which is still disputable, where a recorded ictal systole ended in SUDEP. And all the cases I showed you, it was not ictal systole. There's all rationale to believe that it reproduced the same mechanism of vasovagal syncope triggered by a seizure, probably in the limbic system rather than by the usual trigger of vasovagal syncope. And here again, indeed, the cardiologists tell us it's a self-controlling system of process, so you shouldn't be worried. Now, I think we will need to get a more objective answer, and the MORTEMUS study has collected more than 100 patients with ictal systole and 300 control. And we're trying to finalize the study now looking long term because it was done already 6 years ago. What those patients, how did they evolve? Some of them die or not. And by chance, half of them were paced approximately, the other half were not paced. There might be bias if it was not randomized. But I think that when we will have all this information, we might be able to give an answer. My intuition is that the answer will be we don't have to use this patient, except for avoiding falls, traumatic falls, for those who fall into these ictals. Now, of course, the patient where you have a long-QT syndrome or Brugada syndrome, of course, if you have a genetic mutation in association with the they should be treated as all those cardiac patients are treated now. And here, I think the cardiologists have no issue. It's not what's necessary. There was a second part of the question.
Diagram, please.
Yeah, that's really, again, something on which we can only speculate. But in the future, if the best treatment for preventing SUDEP, or one of the treatments for preventing SUDEP, is having something comparable to a cardiac defibrillator, should it stimulate the heart, respiration, both at the same time? That's an open question. I think that when you come to perform the first trial in using this kind of material, probably it will make sense to stimulate both because it will not be that more complicated than stimulate only one. And you want to give the highest chance possible that such a trial will be effective.
Philippe, thanks for a fantastic talk. It's been said, I think anecdotally, that sleeping alone is a risk factor for SUDEP. And that maybe just physical stimulation of the person might avert it. And that's obviously got relevance to the advice you give, particularly to concerned parents. Do you believe that data? And how do you advise in that situation?
I think the data are relatively convincing. They are not, again, of high-level evidence. It's retrospective data for the most part, observational, not randomized, so never a bias. But it makes sense. And again, the fact is that almost all the SUDEP recorded in a new occur when nobody was there and nobody intervened. Still, there are a few examples of patients who died of SUDEP despite immediate intervention and appropriate CPR. So that means that you cannot necessarily be able to resuscitate every SUDEP patient just because you will stimulate them or even go into a CPR. But I do believe that, yes, most likely the number of patients, simple stimulation will be enough to avoid fatal evolution.
Are there any particular anti-epileptic drugs associated with a lack of tendency for SUDEP?
Sorry, I didn't hear.
Are there any particular anti-epileptic drugs that
well, there has been a lot of discussion, but the latest analysis, and especially performed by Dennis Dorfer in a combined analysis of the 4 respective case control study, led to the conclusion that the number of anti-epileptic drugs and the type of anti-epileptic drug did not have a role. Now, it might lack power to demonstrate that maybe a sodium channel blocker, because that what was previously discussed, carbamazepine and lamotrigine in particular, could carry specific risk. It might have a negative impact in a specific subpopulation. So possibly you will need many more cases to be able to detect that risk.
One more.
And I've also really enjoyed your talk very much. Is there any evidence that SUDEP people at risk may have kind of sentinel events? For example, would it make sense to have people monitored to pick up smaller hypoventilation type procedure or some pattern that could predict what will happen? The stratification of devices is a major issue.
That's an excellent point. You know, when I was alluding to this new biomarker we need to get, that's exactly the kind of biomarker I'm expecting. But it seems to me that the best, most effective way to capture is chronic recording, not active recording in the EMU, and to see the reproducibility over seizure in the normal environment. There are currently retrospective and prospective studies in EMU looking at this issue, including one that was started 5 years ago in France. We have more than 1,000 patients with all the data, pulse oximetry, and EKG. But you recruit 1,000 patients, you need 6 years to eventually have 15 SUDEP be able to analyze this. Again, I do believe that it's likely that by using the appropriate monitoring system chronically in ambulatory patients, invasive or non-invasive, and with non-invasive it will be easier. I'm thinking of the smartwatch, I'm thinking of the tactical device, or whatever in the field, are likely to provide this kind of information. Severity of seizure, through movement you can capture. It might well tell you this is a true generalized clonic seizure, for instance. Pulse oximetry, changes in EKG, different parameters are likely to provide this.
Thank you very much. We'll wind that up there.